I'm Dr. Robert Hamus. I'm a retired plastic surgeon from Dallas and the CEO and president of Ideal Implant Incorporated. I'm here today with David Rapaport, a plastic surgeon from New York City, who was a guest speaker at the Florida Society of Plastic Surgeons meeting in Palm Beach, Florida, which is where we're talking to you from. And David, would you tell us a little bit about yourself and introduce yourself, please?
Oh, thank you, Bob, for having me. I am a board-certified plastic surgeon from Manhattan. Short summary of my career is that I trained at Harvard, at Beth Israel in general surgery, at NYU in plastics. Briefly was in academics at the University of South Florida. I've been in private practice for over 20 years now in Manhattan, doing surgery of the face, breast, and body.
And what is your biggest area that you do? I know your web name is Dr. Cool Sculpt, isn't it?
Well, Cool Spa is
Cool Spa. Excuse me.
Cool Spa is a registered trademark of mine, and that refers to the med spa side of my practice, which delivers cool treatments that work, including cool sculpting.
Okay. Are there other treatments that you do?
Oh, yeah. We do a lot of bipolar radiofrequency treatments in the form of Morpheus, face tight, different ways to rejuvenate the face.
Facial things.
Yeah. Basically a 1-hour procedure under local anesthesia that can make somebody look a lot better. It's not a facelift, but it's so much easier to do. So things like that. We do mirror dry, a procedure that has an 80% chance in one treatment to permanently eliminate underarm sweat and odor.
Wow, that's amazing.
That's pretty cool. We lead the Northeast in that treatment, but there still isn't a lot of public awareness about it, interestingly enough.
So what is the balance in your practice between these non-surgical, or you call them spa treatments, versus surgical treatments, would you say, maybe in terms of your time? We're not talking...
Well, I'm changing that, and I'm changing that deliberately. So I'm in a weird place in my life where even though I have a busy and mature surgical practice, I'm choosing to shift the center of my life actually to Israel. And I've been doing that for a few years now. And next year is going to be the year that I'm going to be in Israel a bit more than half the time. So it's very exciting.
That is a big change.
And what that means is I'm going to be doing less surgery and less injectables. Things, I love doing body contouring. I love doing cosmetic injectables, but I'm going to be in Tel Aviv more. And what I want to do other kinds of work in my life that are even outside the domain in medicine. And in Israel, I have just accepted a part-time job at a public hospital. So that'll be reconstructive. And I'm going to be doing what I missed for the last 30 years. So I'm developing the Cool Spa side and growing that because I really believe strongly, about the idea of a vertical type of med spa, meaning that a plastic surgeon is supervising what's going on, and that when a patient comes in, you give that patient their options. So if there's an aging face, it's like, well, here's what a facelift is like. It'll give you things, but here's what you got to be ready to lose. The scars, the downtime, you get over your fear of anesthesia.
You were a guest speaker for the Florida Society meeting and had a very thought-provoking talk. Maybe give us a little highlights of what your topic was, and it was very well received by the audience. I was privileged to hear it. And
thanks very much. It's basically about the fact that when people make decisions, you can't make a decision that's best for Bob Hamus. David can't make a decision that's best for David Rapaport unless I have the information I need. And then I can choose what's best for me. And I think what it boils down to is it's in our American plastic surgery community where we're in some ways very progressive. We still have dogmas that aren't necessarily fair. So, I have found my career started when you couldn't use a silicone gel implant. So I was using what I call the traditional saline implants. And I learned how to use them, and I learned their strengths and their weaknesses. And I learned that women enjoy the fact that that there's no silicone gel, and so do I in many cases. So the ideal implant just brings that up to a totally different, higher level. But again, there's this safety factor. There are so many issues that so many women feel strongly about, but if they don't know they're there, they can't make a choice. So you can't just walk into a room and say to somebody, this is what's best for you, because that's based on, my assessment of all the trade-offs. And the way I see the trade-off with the ideal implant, I can tell you, I have 4 sons. If I had a daughter, anybody, and this is what I tell my patients, you're getting a breast augmentation. It's typically you're in your 20s or early 30s, usually in your 20s. you're looking at a whole lifelong thing. You want the simplest device possible, the safest thing possible, the least number of things to worry about. So here you've got the lowest rupture rate. You don't have to give a hoot about what's inside of it in terms of being dangerous to you. You don't have to do proactive monitoring. I mean, it sells itself, but they have to get the information.
So why are plastic surgeons reluctant? I've seen that where some plastic surgeons say, I only do silicone gel. I won't even consider an unstructured saline implant, the water balloon, or a structured saline implant. I do gel and that's all I do and I've heard them say it works for me. And
yeah, well, you're not the one with the implants, you know?
Yeah, well, I think that's a good point. So how do you get the surgeons to, I mean, your talk was very, as I said, thought-provoking.
I think history is working on our side, maybe unfortunately, but fortunately.
Well, tell us
in other
about
words,
that.
we're in a state right now where it is the law of the land in the United States that every breast implant has a quote unquote black box warning and a checklist that the surgeon is required to review with the patient. Must be the surgeon that confirms that review, and the doctor signs it and the patient signs it. And that's required. And
now, that wasn't done before, was it?
That was just initiated in the last 30 days or so.
Yeah.
Really,
but I mean, there was discussions and
there was, it's like we were the misbehaving children, I think. So people just didn't want to, to answer your question directly, why isn't this really all over the place? Because I think there are a lot of doctors that maybe just don't want to spend the time. My breast doc consultation's 45 minutes. They don't want to spend the time. Now, there are ways to do this without it. You could show them a video, you could have them read things, but if somebody's having something implanted under their skin that they hope will last as long as possible in a very sensitive area, I think it deserves a conversation. I think that's part of what you need to do. Those aren't free consultations, but I'm spending about an hour of my time.
And it's you that spends the 40. I think that's a key
right.
point that a lot of people don't appreciate, that you as the surgeon, I remember I did that too. I talked to the patient. A lot of surgeons have a patient coordinator or somebody just visit with them for 10 minutes. And
again,
that's it.
You're right. No, it's not that simple, because you have to really know how to, you have to listen to what they're saying to you, listen to their sensitivities, make sure they're understanding what you're saying, see that they understand the options, and help them come to what's best for them. That in terms of deciding whether to use silicone gel or the ideal implant, that decision I've seen virtually always is made at the end of, during that consultation. And 40% of my breast implant practice are ideal. So, and most of those patients thought they were coming to get gel when they came in.
But by informing them, Steve Jobs has a great quote, people don't know what they want until you show it to them. Yeah. And so it sounds like the choice really comes down to either silicone gel or structured saline for the vast majority of cases. The unstructured water balloon isn't much used.
There's only pluses with the ideal. I don't really see minuses. So, where it might suffice in some patients, the ideal will suffice in virtually all of them.
Gotcha.
So it's just, and then, what I'm saying is clearly better is the rupture rate. You just can't compare it. The traditional saline, because it's a less viscous fluid, the folds are sharper. You're going to have a fold flaw failure even more than silicone gel, maybe. Yeah. Now we know silicone gel is such a high rupture rate, much more than we thought.
Yeah.
But again, this is both a lowest in the industry 10-year rupture rate, and you don't need to worry about it at the same order of magnitude.
Now, have you had patients come in and ask you, maybe they're concerned about their gel? Let's say you have a gel implant and the woman's concerned that maybe it's ruptured. What do you do with them? I mean, you're not doing ultrasound in your office.
Not yet. But
you may.
And I think we may. I have a problem. I've known from when I was a surgical resident, and I think it's still true, that the ultrasound is only as good as the ultrasonographer, is the tech. It's very tech dependent, and we learned a little bit about that. So I don't know if I want that responsibility. I have too many things, and I don't. Right. I certainly. I'm
at this point in time, you would send them to a radiologist.
100%. I'd send them. I'd tell them get an MRI or a high quality ultrasound, because again, ultrasounds are not all the same. That's why an MRI, it's more reliable.
Yeah.
It's close to $500 in New York.
Yeah. And so a woman would come in and say, I'm concerned about my rupture. And then your alternative would be to send them for an ultrasound, probably rather than
high quality ultrasound or an
high
MRI.
resolution,
Yeah.
right.
High resolution ultrasound. Correct. And now again, there's many women who they're going to replace the implants no matter what. Let's say because of a contracture, size, or malposition.
They wouldn't even be studied then.
Right, exactly. But they get informed consent, because if it's one thing to do an implant revision, an implant replacement with, let's say, a capsulotomy, just a pocket, little changes in the pocket, versus doing a total or as much of a total capsulectomy. So they get that informed consent that they'll be responsible for a different fee.
And when the person finds out, the woman says, gee, I was concerned it's ruptured and I had an ultrasound and it's found to be intact. Is she relieved then, or how does she feel about it then?
It's not gone away. It's like the alarm goes off in your house and you get up out of bed and check and there's no intruder, but the alarms might go off again. And, the statistics are worse than with an intruder. You can't just buy a German Shepherd, so there becomes a pervasive thing to worry about. Now, I don't know, everybody's from a different place, but in Manhattan, there's a pervasive level of anxiety that's high enough already. Especially about everything, about health. I mean, with COVID, forget about it. We're all a little anxious.
Yeah.
We're all on edge. Women that are making decisions, and I think we know from a lot of reasons, is women are making all the big decisions in families. They understand how to manage risk, and they want lower risk options. And again, we owe it, us plastic surgeons owe it to them to present it to them.
So even if they find out today that their gel implant is not ruptured, they're still going to have the issue in the future. Now,
they still have a gel implant, right?
And if they have an ideal implant, they don't need any of that. They just look in the mirror.
Correct.
They're reassured each day by looking in the mirror that it's intact.
Correct. And we don't know, we don't know enough about breast implant illness to know whether not having silicone gel might help you. But again, it's not going to hurt you. And there's a study that shows that it is a better thing statistically. So again, it's just another factor out of the equation.
Yeah.
I pointed out this morning that, if somebody told me 10 years ago that there was a kind of implant that had a cancer association, I'd have been shocked. So you want to keep what goes into your body as simple as possible. And the ideal implant has the beauty of being a sophisticated device from an engineering point of view. But from what's in your body, it's just some silicone shell and saline fill.
Yeah, it's
natural. I like it.
Yeah, it's
much more natural, much easier. Now, another thing I talked about is how I am very passionate about the option of not having a scar on your breast when you get a breast aug.
And so you can put this in through the armpit incision?
I put it in through the armpit incision. And so it is such an elegant operation. And again, a woman that says, I really don't want to scar my breast ever. Maybe because she just doesn't want it. I don't know anybody that really does want it. But if you're scar prone, if you're Asian, if you have darker skin, if you have a dark C-section scar, then you don't want it. So you get your ideal implant through the underarm. And what's so elegant about it is even on the tiny chance that it ruptures, I can replace that through the underarm.
But the implant goes in empty. So it's got to be easier, I think,
of course,
to put it in through the armpit
than a silicone
gel implant.
Than a silicone gel.
Can a cohesive gel implant be put in through an armpit incision, or is that a struggle?
I've never put textured silicone implants, which again, most people aren't using, right? Any form of texture.
How about what's called cohesive or gummy bear? Can you get that in?
I have put in up to 450 or 500 cc of the regular Mentor smooth round implant cohesive in that it's third generation silicone. They're not that hard. You need a bigger scar and you need a bigger tunnel
to get it in through the armpit.
So when I'm doing ideal, the tunnel is closer to the traditional saline. It's small. Everything is smaller and easier. It's less traumatic to the scar. Yeah, absolutely. Because it goes in empty. It's going in. It's, it's like a flattened banana sort of.
So when did you first hear about the ideal implant and when did you first start using it?
I met you at a meeting more than, I don't know how many years ago, I think it was before the ideal implant was FDA cleared. So it was over
prior to 2015.
Yeah,
okay.
it was way before. And I just loved the idea because I knew that I was a fan of the saline implants. And I also knew what their problems were in terms of rupture and ripples. And so you can't, it just has some inherent problems and the feel of just kind of
water balloon's a water balloon.
This crinkly thing under the skin. So it was like, wow, you've answered a need that I knew I had. I just didn't know somebody had figured this out, how to improve on it. So it was great.
And when was that, do you think? I mean, do you have any idea how long ago this is?
I remember the position I was standing on and what your booth looked like, but I have no idea what city it was in.
We first exhibited starting in 2008. So, and then the device was proved in 14 and we started selling.
It probably
15,
was.
so
It was literally that year that I heard of a couple of peers in New York that were interested and were getting involved too.
And then you started using them in your practice?
Yeah, as soon as I could.
And how did that go at first? I mean, you must have been one of the leaders in New York City to first use it.
It went very well because again, it's not hard to learn from a surgeon's point of view. It's designed very well, and it's we all know how to fill a saline filled device, whether it's a tissue expander or the older implants, and it's just. You follow the instructions and you do it. It wasn't hard at all to adopt. And it's always a pleasure to stand out when it comes to your practice. If if I own a restaurant and I have a dish that very few people can serve, that's great. That's going to draw attention to me.
So is that what happened in your practice? Because you had something novel and unique that differentiated your practice from others.
Oh, that's right. Because like I told you, some of the ideal people are coming and saying, I want silicone gel, but sure, I'll hear, tell me more. But some of them had seen videos I have a couple of YouTube videos of examining my patients and talking about what's in front of us, in front of the camera. And so people are learning more and more. Yeah. But again, we're fighting the man a little bit. I mean, these big companies, it's a different story. This is a smaller company, but again, the fun thing in life is finding things that are good before other people know about them.
Yeah, you have to determine that there's a need and try and address it. The gel implants that I've seen, you mentioned YouTube videos. I've seen YouTube videos of them cutting the implant in half, but I noticed that the gel sticks to the knife that they cut it in half with. Or if they touch it, it sticks to their finger.
It's sticky.
Have you taken out ruptured gel implants?
Bob, my first 5 years in practice were at the University of South Florida. And there was a man there, a doctor, who wrote a book basically saying that all silicone implants ruined your life and you had to take them out. So women came from all over the South. We were doing, 20 a week, 20 explants a week with capsulectomy. So I've seen every size, shape, and form of ruptured implant. And It's disasters. It's not fun. And again, the question I didn't ask today, and I think I'm going to ask if I speak in front of an audience again is, now that you've heard what you heard, what would you tell your daughter to do? What would you rather implant in your daughter?
Yeah. Well, and surgeons who have taken out a ruptured implant, what would make them want to put a gel implant back in?
Listen, if it's what you need, if it's the only way to do the job, suppose it's worth it. You don't have to watch your own operation like Letterman showed his beating heart on TV, I'm told. Yeah. You don't have to do that, but you have an option to avoid the whole thing.
Yeah.
Why not? Why not?
Inform the patient.
Inform the patient. There is that option. You never will have to live through a capsulectomy for a ruptured implant. Yeah. That's pretty cool.
Well, and Ideal Implant is now going into international markets, like we mentioned, Israel. So
I'm changing my life because I want to change my life and I want to give back more and I want to do more, sort of necessary plastic surgery, but that includes reconstruction and a lot of women that need ruptured silicone removed. And right now there's no implant other than silicone gel filled implants. So I'm thrilled that within a couple months, I'm going to be able to offer, and it's exactly when I start working at the hospital, we'll be able to offer our patients. I can teach our residents, and we have the biggest residency in the country of Israel.
Wow.
And I think it's pretty darn intuitive, and like all very progressive countries, more than half of those residents are women. So I think it'll catch on.
And this is both cosmetic and reconstructive in Israel at the hospital you're going to be at?
Well, I'm sure I'll be doing some cosmetic in the private side, but I don't want to be stressed over that. That's a side thing.
Over the years,
I'd rather teach other people, to be honest.
No, I think sharing your philosophy about women getting choices is really important because I think, perhaps it seems they're not getting enough of that. You heard Dr. Salzman's talk about his survey of the women who had the ultrasound study and how many of them were concerned about rupture of gel implants and the peace of mind they had from the idea of an ideal implant or a saline filled implant, that they don't have to worry about that.
Listen, it's very easy to empathize with that, even though I'm not a woman. I don't, it's better when it comes to complex things going into your body to be cynical. I think the environment, we have increase in all kinds of illnesses, and we don't know what the environment's doing to us. And again, the more simple formula of what you put inside your body, the better.
Yeah, you can't beat the safety of saline.
That's right.
Sure.
That is so right.
That is absolutely a point. And if you get a chance, we'll have to get you a saline implant and a structured implant, a silicone gel implant, and you can cut all three of them apart on YouTube. I think that would be pretty interesting to see.
Yeah, that would be a good thing.
Because the saline is totally absorbed. It's so different than the gel, which sticks to the scissors and it's kind of a mess.
Oh, and we all know as surgeons, it's you're cleaning. Yeah. It gets on the floor. It gets. It takes hours to clean those instruments, and you can slip on the floor days later because silicone's an amazing lubricant on a linoleum floor. It's nutty. It's not always a fun product.
Yeah. And when you've used these in your practice, do you use all the different sizes? I mean, have you had patients that are mostly smaller or bigger? Or the whole spectrum?
I know you know this, and you're from Texas, and I'm from New York. The average size of augmentations is much different in the northeastern U.S. than in the South. We're much smaller in New York. So, there's, I'm probably doing more at the smaller 5 sizes and rarely at the larger sizes.
Yeah. I remember when I was practicing in Dallas, we were kind of mid-range in my practice or up. Very rarely did you. But that's Texas back in the day.
Yeah.
So that's
and again, it may be combined with a mastopexy and things. And in those kind of cases, you really don't need very often a big implant. If you're lifting the breast, it's just a matter of helping with the fullness and the projection. But at least again, in the New York crowd, it's keeping it modest.
Yeah. In terms of training surgeons, you're in New York. There's a lot of residency programs in there. Do you ever go and talk to any of the residents at the programs or do a grand rounds or presentation or whatever it might be called? There's all kinds of formats and venues.
Occasionally, yeah. And I'm attending at Manhattan Eye and Ear Hospital at the resident clinic, and I talk to them about stuff. It's funny, again, to me, if I were a resident, just say, well, as a young attending, I think the idea of endoscopic assisted transaxillary breast aug is something you got to do. And again, I'm not like a revolutionary bringing something new to the world. This is big in Asia. This is big in China. Some places have advanced this a lot, and it's really the same thing. And I don't know. I don't want to start, getting people upset, like why it's so hard to be able to give women a saline option. But,
well, you're committed to it. And I think it shows that you feel very strongly. And I have always felt that way too, that women deserve to have choices. There's a lot of power in choices, and they want to feel like they're empowered to choose what they want, which is best for them.
Exactly right. Because again, just like if I'm talking to a woman about whether to do Morpheus and micro liposuction and skin tightening versus a facelift, how can she make that choice if she doesn't know what the positives and negatives are of each? And the truth is, 2 identical faces with different personalities inside will make 2 different choices, and you got to choose what's right for you.
Well, your presentation was excellent at the Florida Society meeting when you were trying to emphasize to the surgeons, and I think the message came through loud and clear to make more a choice of that. So, David, I want to thank you for taking the time from your busy schedule to share with us and visit and share your thoughts. And I thought your presentation was really excellent and well received.
Well, thank you so much, Bob, and it's great being here, and it's just a pleasure trying to have an impact. It's fun.